It's amazing to think that your heart, right now, might be sending out subtle signals, kind of like a secret code that could predict a serious problem, maybe years down the line. And what we're going to dive into today is how these incredible devices, implantable defibrillators, resynchronization things, pacemakers, are being used to decipher those codes. And the really cool part is it's tailored to you. Welcome to the deep dive.
That's exactly what we're looking at, yeah. We're going deep into this super detailed guide. Think guidelines from the American College of Cardiology, along with a bunch of other top medical groups. It's kind of like their playbook. It helps doctors figure out when these implantable devices are they really the best fit for you. And it's all backed by tons of research, years of experience from experts all over.
It's not just like a quick decision, is it? This guide involved so many teams, people from all sorts of specialties, really digging into the data. Then they had this independent panel. Their job was to rate hundreds of different medical situations. So our mission today is to, pull out those crucial bits of information, those golden nuggets, so you can understand, all right, when are these devices a no-brainer? When are they maybe helpful? And when are they probably not the best route? And we want to do it without getting lost in the medical jargon.
And before we jump in, a huge thank you to London Heartbeats Academy in the UK for their support. They've got over 150 courses, so many to choose from if you're interested in learning more. Check them out: Facebook, Instagram, YouTube. They've got all the links for free updates, discussions, definitely worth a look. So, kind of like a roadmap for today. First up, we're going to break down the whole concept of appropriate use criteria. Then we'll dive into specific scenarios. When are ICDs the right call? When is it CRT? When is it pacing? And then just a peek at some of the newer tech that's out there. Things are changing all the time. All right, first things first. These appropriate use criteria, what are they all about?
So picture this. Your doc's trying to figure out the best way to help you, right? AUC, that's what we call these criteria. It's almost like a menu. They list out common heart conditions. And for each one, they give you a rating, like how appropriate is it to use a specific device, let's say an ICD. The rating system is pretty simple. Appropriate basically means the pros most likely outweigh the cons. Then you've got maybe appropriate. That means maybe the evidence isn't totally clear yet, or the experts have kind of different opinions. And then there's rarely appropriate. That's basically saying, yeah, this device is probably not the best choice in this situation.
So it's not like set in stone, right? More like guidelines based on, what we know works best. Absolutely. And these ratings, they don't just come out of nowhere. There was this big panel of experts. They reviewed all the research, used their own experience. We're talking years of experience treating patients. And they use this specific method. It's called the modified Delphi process. It helps them come to a consensus, agree on these recommendations. And a really important thing to remember is AUC, it's there to guide doctors, help them make the best choices for you. But it always has to be used along with their own judgment, looking at your specific situation.
Makes total sense. Now, in the document, I saw this section on general clinical assumptions.
Yeah.
What are some of the key things they assumed were true when they were creating these different scenarios and ratings?
Right. These assumptions, they're like the foundation, the starting point for all the recommendations. So one of the things they assume is whenever your doctor's looking at one of these scenarios, they're assuming you've already had a really thorough evaluation. They're not just jumping into things.
So it's not just about the medical problem, but making sure your wishes are respected, what you want for your health care.
Totally. And another big assumption is this: the ratings. They come mainly from research studies, stuff that's been published, and those established clinical guidelines, the gold standard. But they also know sometimes you got to make recommendations for, groups of patients that haven't been in a ton of studies. And they assume that before even thinking about a device, you're already getting the best treatments out there, what they call guideline-directed medical therapy, or GDMT for short.
GDMT. So that's all the standard stuff, the meds, the lifestyle changes, things we know are effective for that specific heart problem.
Well, right. Yeah, that's exactly it. And another assumption, and this is important, they're assuming there aren't any really unusual challenges like logistical stuff or problems specific to your anatomy, things that could make implanting a device super risky. Unless, of course, those specific problems are actually part of the scenario they're talking about. And then for folks with coronary artery disease, those blockages in the heart arteries, they've got a whole other set of assumptions, like have you had stents, bypass surgery, are those things appropriate?
Right, right. And for CRT, I remember seeing something about sinus rhythm. Why is that so important?
Yeah, so for cardiac resynchronization therapy, they're basically assuming that unless they say otherwise, your heart's in sinus rhythm. That's the normal, regular heartbeat, not atrial fibrillation or some other kind of irregular rhythm. But they do point out CRT can still help some people who have persistent atrial fibrillation as long as the device is programmed right. Making sure it's actually doing its job, keeping those ventricles in sync.
What about pacing from the right ventricle? I remember that being mentioned too.
Oh, that's a really important one. More and more research is showing that if you pace too much from the right ventricle, especially in someone whose left ventricle is already weak, it could actually make things worse over time. So one of their assumptions is doctors are going to try to keep that right ventricular pacing to a minimum, only using it when it's absolutely necessary. And they even suggest sometimes more natural pacing methods like conduction system pacing or even CRT itself might be better options in some cases.
Gotcha. And for ICDs, I think there was something about expected survival.
Right. Yeah. For an ICD to even be on the table, there has to be a reasonable chance that you'll live well for at least a year after it's implanted. They recognize that the people in the studies, they don't always represent everyone who has heart failure, especially when it comes to things like age and other health problems. So they're really emphasizing you got to consider, could age or other serious conditions actually make the risks of an ICD greater than the benefits?
So many factors to consider. It's incredible.
It really is. And they're also assuming that the hospitals, the doctors doing these procedures, they've got the skills, the resources to make sure things go well. And imaging, they're saying that's super important. Things like echocardiograms, MRIs, they help diagnose the problem, guide treatment decisions. They even say those ejection fraction measurements got to be accurate. And just to be clear, these scenarios, they're for real patients, not research studies.
And I saw a little bit about cost and value considerations too. How does that all fit in?
Right, that's a tricky one. And people have a lot of opinions about it. They do acknowledge that cost effectiveness, making sure we're using resources wisely, that's important for the system as a whole, definitely matters to insurance companies and the people making policies. But for a doctor, when they're sitting with you talking about your specific case, their main focus is going to be on the clinical stuff, the benefits for you, the risks for you. So yeah, cost and value matter, big picture, but these expert ratings, they're really focused on you. What's going to make the biggest difference for your health?
That makes sense, putting the patient first. Now let's talk about how doctors actually use these AUC in their everyday practice.
Yeah, they've got some very specific guidance about that. One thing they emphasize is if we can cut down on treatments that are constantly rated as rarely appropriate, that's going to help everybody. Lower costs overall, fewer risks for patients, and without missing out on benefits. And the maybe appropriate category, that's often for things where we don't have all the answers yet, or maybe the experts don't all agree. But just because something's rated may be appropriate doesn't mean it can't help or that it should never be used. And it definitely shouldn't be the only reason your insurance won't cover something.
So maybe appropriate is kind of like a yellow light, not a red light. Proceed with caution and, really consider all those individual factors.
Exactly. They're really stressing that point. These AUC, they're a tool, a guide for making good decisions, but they can't replace the doctor's judgment and their experience. It's about working together.
Okay, so we've got the basics down. The framework, the assumptions, all that. Now let's get into the real nitty-gritty, specific scenarios. And they start by defining some key terms, which I guess makes sense. Got to be on the same page, right?
Oh, for sure. We've got to make sure we're all talking about the same things.
Like they have this very specific definition of clinical heart failure.
Yes.
It's not just about having a low ejection fraction on an echo or being diagnosed with, cardiomyopathy. To actually meet the criteria for clinical heart failure, you got to have the symptoms, the shortness of breath, the fatigue, and you need objective evidence, like fluid buildup or problems with the heart structure.
So someone could have a test that shows their heart muscle is weak, but if they feel fine, no other signs, it wouldn't be considered clinical heart failure in this case.
Exactly. They also define hemodynamic instability. That's when the heart's not pumping well enough, so you get things like really low blood pressure, worsening heart failure symptoms, maybe even passing out. And then there's the difference between ischemic and non-ischemic cardiomyopathy. Ischemic cardiomyopathy means the heart muscle is damaged because it's not getting enough blood, usually because of coronary artery disease. Non-ischemic cardiomyopathy, that's everything else that can cause the heart muscle to not work right.
And what about QRS duration? That's something they measure on an EKG, right? Why is that so important when we're talking about these devices?
Yeah, QRS duration, it's just the width of a certain part of the EKG tracing. Basically, it tells you how fast the ventricles are activated electrically, which leads to them contracting. If it's too long, it could mean there's something wrong with the heart's electrical system. Those signals aren't traveling through the ventricles the way they should. And that's really important when we're thinking about CRT, because CRT is all about fixing that electrical problem, getting the ventricles to beat together again. They also mention it should be a consistent thing, not just a random blip.
And they use the term structural heart disease. That seems like a pretty broad category. What exactly does it include in this context?
It is a broad term. It covers anything that affects the actual structure of the heart, so the muscle, the valves, the big vessels. But in these guidelines, they're specifically saying if you have a genetic arrhythmia, but it only shows up on an EKG, like there's no visible damage to the heart on imaging, that's usually not considered structural heart disease. Unless, of course, it's also causing cardiomyopathy. And just having atherosclerosis plaque build up in the arteries, that's not structural heart disease either, unless it's actually causing problems with the heart muscle.
They also define sudden cardiac arrest and syncope, right? What's the key difference?
So sudden cardiac arrest, that's an emergency. It's life-threatening. The heart just stops pumping effectively. You lose consciousness immediately. You stop breathing. It needs immediate attention, CPR, defibrillation. Syncope, that's basically fainting. It's a sudden loss of consciousness, but then you recover spontaneously. And it's not because of things like anesthesia, a seizure, or a head injury. And importantly, they specifically say syncope is not the same as cardiac arrest.
And the timing after a heart attack, a myocardial infarction, they talk about acute versus recent. Why is that time frame important?
The time since a heart attack, that matters a lot because the risk of having a dangerous arrhythmia and the chance that the heart muscle will recover, those things change over time. So they define an acute MI as within the first 48 hours after symptoms start, and a recent post-MI as up to 40 days after those initial symptoms.
Okay, got it. And they define ventricular arrhythmias, which are abnormal rhythms coming from the ventricles, the main pumping chambers. So we've got ventricular fibrillation, ventricular tachycardia, and then non-sustained ventricular tachycardia.
Right, and they lay all that out. Now, with all those definitions in mind, let's get into the scenarios. First up, secondary prevention of sudden cardiac death with ICDs. What does that even mean?
So secondary prevention, that's when they use an implantable cardioverter-defibrillator, an ICD, in someone who has already had a life-threatening ventricular arrhythmia, like ventricular fibrillation or hemodynamically unstable ventricular tachycardia. Basically, they're trying to stop it from happening again, prevent sudden cardiac death. And the document goes through all these different scenarios. Do they have coronary artery disease? What's their ejection fraction? Were there any temporary or reversible causes for that first arrhythmia?
Yeah, they break it all down.
So if someone had a cardiac arrest, but it was triggered by something like, I don't know, a really bad electrolyte imbalance that got fixed, would they automatically get an ICD for secondary prevention?
Not necessarily. They really stress that you have to figure out why that arrhythmia happened, especially if it could be something temporary or reversible.
Right.
Now, sometimes it's tough to be absolutely sure if there isn't also some underlying problem with the heart's rhythm. And even in those older studies where they thought the cause might be temporary, the risk of having another event later on, it was still surprisingly high. Yeah, it's not always straightforward. Now, the guidelines do say for people who have ischemic heart disease and syncope that they can't explain, if they do an EP study and they're able to trigger sustained VT and the patient has a decent life expectancy, then an ICD might be a good idea.
What about specific conditions like sarcoidosis or myocarditis?
Yeah.
How do those fit in with the recommendations for secondary prevention ICDs?
They address those specifically, yeah. Myocardial sarcoidosis, giant cell myocarditis, even Takotsubo cardiomyopathy, that's the broken heart syndrome. It really depends on the specific diagnosis, the whole clinical picture. But they generally lean towards an ICD being appropriate because those conditions, they do come with a higher risk of those dangerous arrhythmias happening again. And for Takotsubo cardiomyopathy, they generally say you should wait at least 48 hours after the symptoms start.
Makes sense. Now, what if someone has had a life-threatening arrhythmia, but everything checks out? No structural heart disease, no genetic cause they can find. What then?
That's a tougher one. It can be tricky, and they actually have a whole table for that scenario. But basically, if they've had sustained VT or VF, but their heart looks fine on imaging, their ejection fraction is good, then whether they get an ICD depends on a few things, like could something have provoked the arrhythmia, medications, other triggers, and importantly, what does the EP study show? That gives you a lot more info about the heart's electrical system.
Right. And syncope, Or fainting, how does that factor into decisions about secondary prevention ICDs?
So, if someone has coronary artery disease and syncope and they can't figure out why they're fainting even after all the tests, an ICD might be something to consider, especially if they've had a heart attack before or have really bad blockages in their arteries. And the same goes for people with certain cardiomyopathies, like arrhythmogenic right ventricular cardiomyopathy, non-ischemic dilated cardiomyopathy, or hypertrophic cardiomyopathy. Again, unexplained syncope, it can raise the question of an ICD. But it really comes down to things like their ejection fraction, the results of the EP study. Oh, and with arrhythmogenic right ventricular cardiomyopathy, they often say an ICD is appropriate even if they can't trigger any arrhythmias during the EP study, because that condition itself has such a high risk of sudden cardiac death.
Okay, so that's secondary prevention. Let's move on to primary prevention of sudden cardiac death with ICDs. Now, we're talking about trying to prevent it before it even happens, right?
Yeah, exactly. Trying to be proactive. And with primary prevention, it's all about identifying those folks who are at high risk for sudden cardiac death, but they haven't had one of those scary arrhythmias yet. And one thing they really stress is timing. You know, when you put in the ICD, especially after a heart attack or revascularization procedure, they generally say wait at least 40 days after a heart attack and at least 3 months after a revascularization. That comes from studies like IRIS and Dynamite. Those studies showing that putting in an ICD too soon after those events, it didn't really help, and in some cases might have even caused harm.
So even if someone has a low ejection fraction after a heart attack, they don't just automatically get an ICD right away. There's a waiting period.
Right. Not for primary prevention. You got to give it some time. And the specific scenarios they lay out, it really depends on a few things. The ejection fraction, the NYHA functional class that describes how bad their symptoms are and how long they've been on GDMT, those guideline-directed meds. So, for example, if someone has ischemic cardiomyopathy and their ejection fraction is 35% or less, and they've been on GDMT for at least 3 months, but their heart function hasn't gotten much better, an ICD for primary prevention, that's often considered appropriate. That 3 months on meds, it gives the heart a chance to recover on its own or with the meds, so they're not putting in a device unless they really need it.
What if someone has a low ejection fraction after a heart attack, and then early on they also need a pacemaker? Does that change things?
Oh, yeah, that's a specific situation they talk about. If their ejection fraction is really low after a heart attack or a revascularization, and then they need a pacemaker pretty quickly, let's say within those first 40 days or 3 months, then yeah, it's usually better to put in a device that can do both, pacing and defibrillation. Basically, it's an ICD that can also act as a pacemaker. That way you don't have to do another surgery later if it turns out they need that ICD protection.
And what if they already had cardiomyopathy before they had the heart attack or the revascularization? Does that affect the waiting period?
If they already had cardiomyopathy and their ejection fraction was 35% or less for at least 3 months before something happened, like a heart attack, then those IRIS and Dynamite studies, they don't really support putting in an ICD within that 40-day window. And same thing if they had a low ejection fraction before they had a revascularization. You wouldn't automatically put in an ICD within those 3 months. Unless, of course, they also need a pacemaker during that time, like we just talked about. The main thing is to figure out what their risk really is after they've had enough time to respond to the GDMT, those guideline-directed meds.
So it's not just about the numbers, it's the whole picture.
Exactly.
Now, what about primary prevention in non-ischemic cardiomyopathy? Is it the same approach as ischemic cardiomyopathy?
It's similar in that the ejection fraction, the NYHA class, those are still super important. But with non-ischemic cardiomyopathy, they also really pay attention to how long the person has been on those GDMT meds. So usually if it's non-ischemic, ejection fraction 35% or less, they might think about an ICD for primary prevention after they've been on those meds for at least 3 months and their ejection fraction is still low. But there's a caveat sometimes with non-ischemic cardiomyopathy, the heart function can get better over time, like if it's peripartum cardiomyopathy or tachycardia-induced cardiomyopathy. So that can affect whether they decide to put in an ICD or not.
So many nuances. What about genetic heart conditions? How do those factor into the recommendations for primary prevention ICDs?
That's a whole other ballgame. Those genetic conditions, they can be way riskier than, regular heart failure from other causes. So for those genetic things that actually change the structure of the heart stuff, like hypertrophic cardiomyopathy, especially if they have certain risk factors, or arrhythmogenic right ventricular cardiomyopathy, or cardiac amyloidosis, sarcoidosis that's affecting the heart, Chagas disease, left ventricular noncompaction. Those mutations in the lamin-C gene for all those, they often say an ICD is a good idea for primary prevention, even if their ejection fraction isn't as low as that 35% cutoff we usually talk about. That's because those conditions, they have a much higher risk of sudden cardiac death just because of how they affect the heart electrically and structurally.
The underlying condition itself changes the whole risk calculation.
Exactly. Now, for other genetic arrhythmias where you don't necessarily see structural changes on imaging stuff like long QT syndrome, catecholaminergic polymorphic ventricular tachycardia, Brugada syndrome, for those, whether they get an ICD really depends. What are their symptoms like? What does their EKG look like? How are they responding to medications?
So much to consider. And of course, a lot of people who have heart failure, they've got other health problems too, right? Comorbidities.
Yeah.
So how do those other conditions affect the decision-making for primary prevention ICDs?
Yeah, that's huge. You can't ignore those. They point out that for folks with heart failure and a low ejection fraction, the benefit of an ICD might not be as big if they're older or have other serious conditions, things like diabetes, chronic kidney disease, especially if they're on dialysis, or if they're frail, or if their heart failure symptoms are already really advanced. The thinking is, as the risk of dying from other things, what they call non-sudden death, goes up, the benefit of an ICD, which is specifically for preventing sudden cardiac death, that benefit might go down. It's a balancing act. You're weighing the risk of sudden cardiac death against their overall risk of dying from any cause.
Right, so it's not just about preventing one specific thing, it's about their overall health picture.
Exactly. And they even mention this thing called the Seattle Proportional Risk Model. It's a tool that can help doctors estimate the chances of sudden death versus non-sudden death. You know, things like younger age, less severe symptoms, lower ejection fraction, no diabetes. Those things tend to mean a higher proportion of their risk is from sudden death.
Makes sense. Are there specific comorbidities that would make an ICD rarely appropriate for primary prevention?
Yeah, they list a few, like if their life expectancy is less than a year because of other health problems, or if they're over 90 and only have mild heart failure, or if they're not able to understand the risks and benefits well enough to give informed consent, or if they have a really severe psychiatric illness, you know, something that could get much worse with the device or that would probably make it hard to get proper follow-up care. Active drug use is another one because of the infection risk. And if they have an infection that's going on and could spread to the device, or if they haven't been taking their medications like they should, and really severe heart failure like NYHA class 4, if they're not eligible for things like a transplant, CRT, or an LVAD.
Wow, so those are the really clear no situations.
Pretty much.
Mm.
They also say if someone has a lot of non-cardiac problems that limit their life expectancy maybe to 1 or 2 years, or if they're between 80 and 90, that might be a maybe appropriate situation.
Right, because the risks might outweigh the benefits at that point.
Exactly. And remember, older people, they weren't always well represented in those big ICD studies, so we don't always have as much data.
That makes sense. I also saw something about ICDs being used as a bridge to transplant. What does that mean?
So for people who have really severe heart failure, like NYHA class 4, and they're waiting for a transplant, an ICD can be a good way to protect them from sudden cardiac death while they're waiting for a donor heart. It's like a temporary safety net. But if they've already got an LVAD, a left ventricular assist device, then an ICD is more of a maybe appropriate. And for folks with class 4 heart failure who aren't eligible for a transplant, CRT, or an LVAD, and they're still having terrible symptoms even with the best meds, or if they need continuous IV meds just to stay comfortable, then an ICD is usually considered rarely appropriate.
Okay, let's shift gears a bit.
Yeah.
What about when someone already has an ICD and the battery's dying? What do they need to think about for elective ICD generator replacement?
So if their ICD has already gone off, you know, it's delivered therapy because they had a life-threatening arrhythmia, then when it's time to replace the battery, they're basically in the secondary prevention category. But if they originally got the ICD for primary prevention, just based on their risk, and the device has never actually had to do anything, no shocks, no pacing therapy, then it's a little less clear. There isn't as much research to tell us what to do. And in a lot of cases, they just go ahead and replace it anyway, regardless of how their heart is doing at that point.
So even if their heart function has gotten a lot better since they got that first ICD, they might still replace the generator.
There is some research that suggests that even if their ejection fraction improves and the device hasn't gone off, they might still be at risk for arrhythmias in the future. But deciding whether to replace it or even upgrade it to a fancier device, it's not a risk-free decision. So the document talks about different situations. Just replacing the ICD, replacing a CRT ICD, maybe even downgrading to a regular pacemaker. More research is definitely needed there.
Right, right. What about the type of ICD? I saw a section on dual-chamber ICD implantation. When would you use a dual-chamber ICD instead of a single-chamber one?
The idea behind dual chamber ICDs is that they might be better at telling the difference between those fast but not so dangerous rhythms coming from the upper chambers, things like supraventricular tachycardias, and the really dangerous ventricular arrhythmias. So they might give fewer inappropriate shocks for rhythms that aren't life-threatening. But even though that makes sense in theory, the big studies haven't really shown that dual chamber ICDs are that much better overall, especially for people who are getting the device for primary prevention.
So it's not a slam dunk, especially for primary prevention.
Not really. They do talk about specific situations where a dual chamber ICD might be a better choice, like if the person also has bradycardia, their heart rate is too slow and causing symptoms, or if they have problems with the heart's electrical system, things like AV block or sinus bradycardia, they might need pacing from both chambers. And they talk about using dual chamber ICDs for some atrial arrhythmias too. And they mention specific conditions like long QT syndrome and hypertrophic cardiomyopathy. But using a dual chamber ICD, just because it might be better at telling the difference between rhythms when they don't need pacing, that's considered maybe appropriate now. It reflects how the thinking is changing.
So interesting how the guidelines evolve as we get more data. Now, they also talk about totally subcutaneous ICD, SICD. What's different about those?
A totally subcutaneous ICD, or SICD, is really unique. All the parts, the generator, the lead, everything, it's all under the skin. Nothing goes inside the chest or into the heart or blood vessels. It's specifically for people who need an ICD, to prevent sudden cardiac death, but they don't need pacing for a slow heart rate. They don't need anti-tachycardia pacing to stop those fast ventricular rhythms, and they don't need CRT.
So it's like a simpler system.
In a way, yeah. And one of the big advantages is you're not putting leads through the blood vessels and into the heart. So there's a much lower risk of infection. And you don't have to worry about lead problems, like them breaking or moving out of place. Younger people, they might need multiple lead replacements over their lifetime. So for them, this could be a big deal. And another thing with an SICD, you don't always need X-ray guidance to put it in.
Are there any downsides to the SICD?
Well, the current SICDs, they can't pace for a slow heart rate, and they can't do anti-tachycardia pacing. So if you need those things, it's not an option. And you have to be really careful before you put one in to make sure it's not going to misinterpret the heart's normal electrical signals, especially those T waves, as dangerous arrhythmias. You don't want it giving inappropriate shocks. But there have been some big studies, like the Effortless Registry and the Untouched Trial, that showed that SICDs can be safe and effective in real-world situations, even for primary prevention. That Effortless study, they had all sorts of patients, different cardiomyopathies, other health problems.
So if you need an ICD but not pacing, the SICD could be a good alternative.
It definitely can be in the right person. They've got scenarios in there for primary and secondary prevention for all kinds of cardiomyopathies, even for people with end-stage renal disease who are on dialysis, or if they've had infections in their blood vessels before. Because putting in those transvenous leads, that would be riskier for them. Now, for people who are actively using IV drugs, the SICD is rated as maybe appropriate. There's still an infection risk, but it might be lower than with the traditional system. And there was this ATLS study. It showed fewer lead complications with SICDs, and the shocks worked just as well. There might be a bit more pain right after the surgery, and maybe a slightly higher chance of inappropriate shocks because of those T waves. But overall, it looked good. And the Untouched Trial, that one focused on primary prevention in people with low ejection fractions, and they had good results too, prevented sudden death, and the rate of inappropriate shocks was low.
Awesome. And now onto cardiac resynchronization therapy, or CRT. Who benefits from that?
CRT, that's a special treatment for people who have heart failure with a low ejection fraction and a prolonged QRS duration on their EKG. That prolonged QRS means that the ventricles, the bottom chambers, they're not contracting in sync. The signal's getting delayed. So CRT, usually it involves a pacemaker or a defibrillator, but it has special leads that stimulate both ventricles. It's like a conductor, getting them to beat together again, which makes the heart pump better.
So it helps a weak heart beat more efficiently.
Exactly. And there are measurable benefits. Studies have shown that CRT can actually make the left ventricle remodel get smaller and more efficient. Their heart function improves overall. They're less likely to have those dangerous arrhythmias. Their symptoms get better. They're hospitalized less for heart failure, and they even live longer. And it works even better when you combine it with good medical therapy.
It's amazing how much these devices can do.
It is. Now, the document goes into detail about exactly when CRT is indicated. It depends on things like whether the heart failure is ischemic or non-ischemic, their NYHA functional class, their ejection fraction, and the specific pattern of that QRS complex on the EKG. Like, is it a left bundle branch block? So, for example, if someone has pretty bad symptoms, like NYHA class 2, they're even ambulatory class 4, and their ejection fraction is 35% or less, and their QRS duration is 150 milliseconds or more with a left bundle branch block pattern, then CRT is usually a good call. And the shape of that QRS complex, specifically whether it's a left bundle branch block or not, that's really important for figuring out who's going to respond best to CRT.
And what about the people who need both CRT and an ICD?
Yeah, a lot of CRT devices actually have defibrillation capabilities built in. They call those CRTDs. And when you're deciding whether to use one, it's basically combining the criteria for CRT and the criteria for an ICD. So the document has scenarios for that overlap. Like if someone's ejection fraction is between 36% and 50%, but they have other risk factors that would make you think about an ICD, then a CRTD might be the way to go. They also talk about using CRT in people who might need a lot of right ventricular pacing for other reasons because CRT can actually help offset those negative effects that right ventricular pacing can sometimes have. But it's important to note that CRT isn't for everyone. They don't usually recommend it if someone has really advanced heart failure.
First scenario we're looking at is patients with an LVEF of 35% or less.
LVEF, that's left ventricular ejection fraction, right?
You got it. It measures how much blood the left ventricle pumps out with each beat.
So 35% or less, that indicates a pretty weak heart.
Right. Now, we also need to consider whether these patients are in what's called normal sinus rhythm.
Sinus rhythm, that's just the normal, regular heartbeat, right?
Exactly. And within this group of patients with a low LVEF and sinus rhythm, a key factor is the QRS duration.
QRS duration, what is that exactly?
Well, it's measured on an ECG, an electrocardiogram. It basically tells you how long it takes for the electrical signal to travel through the ventricles of the heart.
So it's like the electrical activation time for the heart's main pumping chambers.
That's a good way to put it. And if the QRS duration is less than 120 milliseconds, which is considered relatively short or narrow, the guidance suggests that an ICD is rarely appropriate.
And that's regardless of the patient's NYHA functional class, just as a reminder for our listeners.
Good point. The NYHA classification is how doctors grade the severity of someone's heart failure symptoms.
Class I is pretty mild. You might have heart disease, but don't really feel limited in your daily activities.
Right. And then class 4 is the most severe. Even at rest, you're having significant symptoms.
So even if someone's in class 4, but they have a narrow QRS, in this specific scenario of non-ischemic cardiomyopathy, low LVEF, and sinus rhythm, an ICD probably isn't going to do much good.
Exactly. The evidence just doesn't really support its use in those cases.
But things start to change when that QRS duration gets wider.
Right. So let's say it's between 120 and 149 milliseconds, and there's also a left bundle branch block, or LBBB, on the ECG.
Now, the LBBB, that's a particular pattern on the ECG that indicates a delay in the electrical activation of the left ventricle.
It's like one side of that main pumping chamber is lagging behind the other.
Okay, so in this situation, a moderately wide QRS plus LBBB, the ICD recommendation shifts.
It becomes maybe appropriate for class 1, but bumps up to appropriate for those with more severe symptoms, class 2 to 3 ambulatory.
So it sounds like that combination, the wide QRS and LBBB, really makes a difference.
It sure does. It suggests a specific electrical problem that might make those dangerous arrhythmias more likely.
And if the heart failure symptoms are more noticeable, then the potential benefits of an ICD might outweigh the risks.
Right. And what if that QRS duration gets even wider, 150 milliseconds or more, still with that LBBB and sinus rhythm?
What happens then?
Well, then it becomes appropriate for all NYHA classes, from I to IV. So that's a pretty clear signal.
A wide QRS with LBBB, especially in patients with low LVEF from non-ischemic cardiomyopathy, an ICD is definitely something to consider.
Agreed. The evidence supports it. Now let's go back to that moderately wide QRS, the 120 to 149 milliseconds, but this time there's no LBBB.
Okay, so same scenarios of for low LVEF sinus rhythm, but no LBBB. Does that change the recommendations?
It does. Without that LBBB, the ICD is rarely appropriate for class 1 and 2, but it goes up to maybe appropriate for class 3 ambulatory,
So the absence of that LBBB pattern does seem to matter.
especially for those with less severe symptoms. It's just not as clear-cut whether the ICD would be beneficial.
And finally, for this group, what if the QRS is 150 milliseconds or greater, but again, no LBBB?
In that case, it's maybe appropriate for class 1 and 2, but becomes appropriate for class 3 ambulatory. So even without the LBBB, a very wide QRS still raises the stakes.
It seems like that very prolonged QRS, whether or not there's LBBB, really points to a greater likelihood of those dangerous rhythms.
Right, especially as the heart failure symptoms get worse.
Okay, so far we've been assuming these patients with low LVEF are in normal sinus rhythm.
Right, that nice regular heartbeat.
But what if they have atrial fibrillation, that irregular rhythm where the upper chambers of the heart are just going crazy?
Good question. Atrial fibrillation definitely throws a wrench into the mix.
So how do the recommendations change for these patients with low LVEF and atrial fibrillation?
Let's start with a QRS between 120 and 149 milliseconds and a LBBB. The rating for an ICD becomes maybe appropriate in that case.
And what if the QRS is even wider, 150 milliseconds or more, still with LBBB and atrial fibrillation?
Then it becomes appropriate. So similar to sinus rhythm, that wide QRS and LBBB pattern still matters.
It's just that atrial fibrillation throws in some uncertainty.
Exactly. The irregular rhythm from the atria makes it harder to predict those dangerous ventricular rhythms.
Okay, what about when there's no LBBB in these patients with low LVEF and atrial fibrillation?
If the QRS is 120 to 149 milliseconds, or if it's 150 milliseconds or more, the recommendation in both cases is maybe appropriate.
So without that specific LBBB pattern, even a wide QRS doesn't make the decision clear-cut.
It really highlights how that LBBB seems to be a key indicator in these low LVEF patients with atrial fibrillation.
Now, what about when the LVEF is a bit higher, not quite as bad? Say it's between 31% and 35%.
Okay, and we're still talking non-ischemic cardiomyopathy and sinus rhythm for now.
Right. Do the QRS duration and LDBB still play the same role in the recommendations?
They sure do.
Yeah.
It's really quite consistent with what we saw in the lower LVEF group.
Yeah.
If the QRS is less than 120 milliseconds.
That's that narrow QRS we talked about before.
Right. It's rarely appropriate no matter the NYHA class.
And for a QRS between 120 and 149 with LBBB?
May be appropriate for class 1 and appropriate for class 2 and the third ambulatory.
And if the QRS is 150 or more with LBBB?
Appropriate for all classes. So even with a slight bump up in LVEF, those electrical characteristics, the QRS duration and LBBB, really drive the recommendations.
It's like that electrical instability might be just as important as how well the heart is pumping.
I'd say so.
And just to make sure we're covering all our bases, what about when the QRS is 120 to 149 without LBBB? Still in this 31% to 35% LVEF group.
Same as before, rarely appropriate for class 1 and 2, and may be appropriate for class 3 ambulatory.
And if the QRS is 150 or greater without LBBB?
May be appropriate for class 1 and 2, and appropriate for class 3 ambulatory. The pattern holds.
Okay, good to know. So it seems like that QRS duration is a pretty solid indicator across the board.
You got it. Now, are you ready to move on to table 7.3?
Absolutely. Let's do it. What's up next?
This table looks at patients with a slightly higher LVEF. We're
Right.
talking greater than 35%, but no more than 50%.
So their heart's pumping a bit better than the previous groups.
Exactly. And this table applies to any cause of cardiomyopathy. It doesn't have to be non-ischemic.
Okay, good to know.
And the focus here is on situations where an ICD might be indicated.
Got it.
This table also looks at whether the patient is in sinus rhythm or has persistent or permanent atrial fibrillation.
Ah, so they are taking that into account as well. Interesting.
Yes, it breaks it down by those rhythms and by NYHA class, from SCAI all the way to the third ambulatory floor.
So what are we seeing in this group, the ones with a slightly better LVEF? Are ICDs as common?
Well, not really. The big picture is that ICDs are generally less likely to be considered appropriate in this group, especially compared to those with the more severely reduced ejection fractions, like 35% or less.
Makes sense. If the heart's pumping relatively well, maybe those dangerous rhythms aren't as big a concern.
Right. And if the QRS duration is less than 120 milliseconds, remember that's a normal QRS.
I'm getting the hang of this.
The recommendation is consistently, rarely appropriate, no matter the rhythm, no matter the NYHA class.
So a normal QRS decent LVEF, no need to jump to an ICD, it seems.
That's generally the takeaway.
Okay, but what if the QRS duration starts to widen a bit?
Good question. If it's between 120 and 149 milliseconds, and we've got that LBBB pattern present.
Ah, LVBB, that familiar culprit.
For patients with milder symptoms, NYHA classing D, it's rarely appropriate.
Okay, so still not a strong indication for an ICD.
But for those with more significant symptoms, class 3 ambulatory fee, it shifts to may be appropriate. And this holds true for both sinus rhythm and atrial fibrillation.
So even with a better LVEF, the LDBBB pattern, especially when the symptoms are worse, starts to tip the scales.
It does. It just suggests that something's not quite right electrically.
Makes sense. And what if the QRS is even wider, 150 milliseconds or more, and we still have that LBBB?
In that case, it's maybe appropriate for both the less severe symptoms and the more advanced symptoms. Again, in both sinus rhythm and atrial fibrillation.
So a very wide QRS, even with a better LVEF, definitely warrants some thought.
It does. It's like a red flag that should be ignored. Now, let's say the QRS is between 120 and 149 milliseconds, but no LBBB this time.
Okay, so same QRS range, but no LBBB in this LVEF greater than 35 to 50% group.
In this case, it's consistently rarely appropriate across the board. All NYHA classes, sinus rhythm, and atrial fibrillation, it doesn't matter.
So that lack of LBBB, combined with the better LVEF, really seems to make an ICD unnecessary.
Generally speaking, yes. And finally, for this group, what if the QRS is 150 milliseconds or greater, but again, no LBBB?
Okay, so a really wide QRS, but without that specific LBBB pattern.
It's rarely appropriate for the milder symptoms, but becomes maybe appropriate for the more significant symptoms. And again, this is the same whether the patient is in sinus rhythm or atrial fibrillation.
So even without LBB, a super wide QRS in someone with more noticeable heart failure and a moderately reduced LVEF might be cause for a closer look.
Right. It's definitely something to consider and discuss with the patient.
Now, Table 7.4 gets really specific. We're talking about patients who have an LVEF of 35% or less.
Okay, so a pretty weak heart.
And they're in NYHA class 4, meaning they have really severe heart failure symptoms, even at rest.
This is a very sick group of patients.
And on top of all that, they're receiving intravenous inotropic support to help their heart pump.
Wow, so they're really getting the full court press in terms of treatment.
Exactly. In these very sick individuals, what does the guidance say about ICDs?
Well, if they have a QRS between 120 and 149 milliseconds, plus that LBBB pattern, and they are in sinus rhythm, ICD implantation is considered rarely appropriate.
So even in this dire situation, it's not a slam dunk for an ICD.
Right. But if that QRS is wider, 150 milliseconds or greater, still with LBBB and sinus rhythm, then it shifts to may be appropriate.
So that wider QRS with LBBB does seem to make a difference even in this advanced stage of heart failure.
It does. It might identify a group who could benefit from the protection an ICD provides against those sudden death arrhythmias.
And just to be thorough, what if there's no LBB in these class 4 patients who are on inotropes and in sinus rhythm?
Then the ICD recommendation is rarely appropriate, whether the QRS is 120 to 149 milliseconds or 150 milliseconds or greater.
So without LBBB, even in the sickest group, an ICD is less likely to be beneficial.
That seems to be the takeaway from the evidence. And what about those same class 4 patients on inotropes, but instead of sinus rhythm, they have atrial fibrillation?
Ah, good point. We need to consider how atrial fibrillation changes things.
Absolutely. So if they have a QRS duration between 120 and 149 milliseconds with that LBBB pattern, and they are in atrial fibrillation, ICD implantation is still considered rarely appropriate.
Okay, so similar to what we saw with sinus rhythm.
Right. But if that QRS duration is 150 milliseconds or greater, still with LBBB and atrial fibrillation, it becomes maybe appropriate.
So the presence of LBBB with that wider QRS still seems to be the driving force.
Exactly. But if there's no LBBB in these class 1B patients with atrial fibrillation and low LVEF, then it's rarely appropriate, regardless of the QRS duration.
So again, it seems that without LBBB, the benefit of an ICD in this very sick group is much less clear.
Precisely. The combination of advanced heart failure, atrial fibrillation, and the absence of that significant electrical delay pattern of LBBB really makes the potential benefits of an ICD uncertain. Now, let's shift gears a bit and talk about cardiac resynchronization therapy. or CRT.
CRT. We've mentioned it a few times, usually in the context of ICDs, but what exactly is it and who benefits from it?
Well, CRT is a treatment specifically designed for patients who have heart failure with a reduced ejection fraction and also have something called electrical desynchrony.
Desynchrony, that means the heart's ventricles aren't contracting together in a smooth, coordinated way.
You got it. And that makes the heart less efficient at pumping blood.
So how does CRT help?
Typically, it involves implanting a special type of pacemaker. This one has leads that go not only into the right ventricle, but also into the left ventricle.
So it's like a 2-for-1 pacemaker.
You could say that. It allows both ventricles to be paced in a way that gets them back in sync. And the document we're looking at really highlights how CRT can improve a patient's quality of life.
Less symptoms, fewer hospitalizations.
Exactly, and potentially even longer survival.
That's huge. And it seems like CRT works best when it's used along with the best available medications for heart failure.
Absolutely. It's not a replacement for those medications. It's all about a combined approach.
And for patients who need both an ICD and CRT?
Well, they often get a single device called a CRTD.
CRTD, so it does both.
Exactly. And the data shows that the survival benefit of a CRTD is sustained over time.
That's really important for both patients and their doctors to know.
I agree. Now, the document also makes a very clear point, regardless of the cause of the heart failure.
Whether it's from coronary artery disease or something else.
Right. CRT is generally not recommended if the patient has a narrow QRS duration on their ECG.
Okay, so we're back to that QRS duration again. It seems like it's a key factor for CRT, just like it was for ICDs.
It definitely is.
Yeah.
A wider QRS is usually the starting point for even thinking about CRT.
But how does that specific QRS duration and whether or not there's LBBB affect the decision?
Well, generally, as the QRS duration gets wider, especially with LBBB present.
That specific pattern we talked about before.
Right. The appropriateness of CRT tends to increase. And the document has some really detailed tables that break it all down.
I'm glad we don't have to go through every single scenario right now.
Me too.
Right.
But the main takeaway is that CRT is really designed to address the type of electrical discoordination that often goes hand in hand with a wide QRS, particularly when LBBB is involved.
So it's not just about the width of the QRS, but the specific pattern too.
Got it. And of course, the patient's symptoms also play a role.
We're talking about the NYHA functional class again.
Exactly. Those with more severe symptoms tend to get more benefit from CRT than those with milder symptoms.
Makes sense. And what about atrial fibrillation? Does that change things?
It can. Patients with atrial fibrillation often see less benefit from CRT compared to those in normal sinus rhythm.
Probably because that irregular rhythm from the atria throws a wrench into things.
That's likely a big part of it. It makes it harder for that carefully timed pacing from CRT to really work its magic.
And what about when the LVEF is in that higher range, greater than 35, but no more than 50%?
In those cases, CRT is usually considered rarely appropriate, meaning it's not really recommended.
So if the heart is pumping relatively well, even with those electrical abnormalities, CRT isn't usually the answer.
Right.
Now, what about for those very sick patients we talked about earlier? The ones in NYHA class 4 who are on continuous intravenous inotropic support.
Ah, yes, those with really advanced heart failure.
Is there any place for CRT in those patients?
Potentially. The document suggests CRT may be appropriate, but only if they have both a LBBB and a QRS duration of at least 150 milliseconds.
So a very specific and narrow group within this very sick population.
Exactly. And even then, it's maybe not a definite recommendation.
It just shows how nuanced these decisions can be.
They really are. And the same goes for those patients with really tough to treat heart failure. You know, the ones who are still having severe symptoms, despite being on the best possible medical therapy.
So refractory heart failure, as it's sometimes called.
Exactly. And in those cases, CRT may be appropriate, again, depending on the presence of LBBB and that wide QRS of 150 milliseconds or more.
It's really striking how that LBBB pattern and the QRS duration keep coming up as key factors.
It's not just about how weak the heart is, but how uncoordinated those electrical signals are.
Okay, so to recap on CRT, it's not just one thing that determines if it's the right choice.
You're absolutely right. It's this whole combination of factors: the severity of the heart failure symptoms, the electrical patterns on the ECG, the LVEF, and the underlying heart rhythm.
A lot to juggle, for sure.
Definitely. It's all about looking at the individual patient and figuring out what's best for them.
And speaking of looking at the individual patient, Table 7.5 focuses on a very specific scenario. We are talking about patients who already have or are expected to need right ventricular pacing.
Okay, so they have a pacemaker already, or they're likely going to need one soon.
Right. And on top of that, they meet the criteria for either an ICD or a standard pacemaker.
So they have a dual indication, so to speak. Interesting.
It is. And this table dives into how that pre-existing or anticipated right ventricular pacing affects the decision about adding CRT.
Because wouldn't CRT just add more pacing?
Yeah.
Seems a bit counterintuitive.
It might seem that way, but here's the thing. The evidence is showing that frequent pacing from the right ventricle alone,
Like what you'd get from a traditional pacemaker.
right, that can actually be bad for the heart in the long run.
Really? How so?
It can potentially lead to or worsen left ventricular dysfunction.
Oh, wow. That's a significant downside.
It is. So if a patient is already getting a lot of right ventricular pacing, or they're going to need it in the future.
Say because they have a slow heart rate or heart block?
Exactly. And they also need an ICD or a standard pacemaker, then adding CRT is usually considered appropriate.
Interesting. So you are essentially adding left ventricular pacing to counteract the potential negative effects of the right ventricular pacing.
That's the idea. Helps keep the two ventricles in sync and prevents those potential long-term problems.
So it's a more proactive way to manage those patients who require a lot of pacing.
Exactly.
Makes sense.
Now, Table 7.7 shifts our focus to heart failure patients who also have right ventricular dysfunction.
Okay, so now we are specifically looking at problems with the right side of the heart.
Right. And this table lays out a very specific scenario. A patient has had an inferior myocardial infarction,
That's a heart attack affecting the bottom part of the heart.
and their LVEF is okay, greater than 35%, but their right ventricle is not doing well. It's severely dysfunctional.
Okay, got it. So their left ventricle is pumping fine, but their right ventricle is struggling.
Exactly. And crucially, this patient doesn't need any ventricular pacing.
So no need for a pacemaker to speed up their heart rate?
Right. Now, if this patient has a QRS duration between 120 and 149 milliseconds,
So moderately wide QRS.
but no LBBB, and they are having significant heart failure symptoms, then CRT is considered rarely appropriate.
So even though the right ventricle is weak, CRT isn't really recommended in this scenario,
It seems that way. The main focus of CRT is still on that left ventricle.
making sure it's contracting effectively and in sync with the right ventricle.
Exactly.
Got it. Moving on, Section 8 of the document tackles a really complex topic. Heart failure patients with LVADs. That stands for left ventricular assist device.
Oh, yeah, those are serious business. It's like a mechanical pump that helps the heart do its job.
They're often used for patients with very advanced heart failure.
So for these patients who already have this mechanical support, what are the considerations when it comes to also having an ICD?
Well, it's actually a bit controversial. The evidence about whether an ICD is truly beneficial in patients with LVADs is mixed,
Some studies say yes, some say no.
basically. So the guidance suggests that if a patient didn't have an ICD before getting the LVAD,
So de novo implantation?
right, it might be reasonable to consider implanting one afterwards.
But if they already had an ICD?
Then it should stay active and turned on.
Okay, so a cautious approach, acknowledging that we don't have all the answers yet.
Exactly.
Now, what about managing the ICD in someone who also has an LVAD? Any special considerations there?
Good question. Routine ICD care, like checking the battery and replacing the generator when needed, is usually continued.
Makes sense.
But more involved procedures, like replacing or repositioning the ICD leads.
The wires that go to the heart.
Right. Those require a very careful risk-benefit analysis.
Why is that?
Well, LVAD patients are typically on blood thinners to prevent clots.
To prevent strokes and other complications?
Exactly. And that can make these procedures riskier.
Okay, so it's a judgment call based on the individual patient.
Absolutely. Now, here's an interesting point. Since the LVAD is doing so much of the work, helping the heart pump.
Taking over for that weakened left ventricle.
Right. Patients with LVADs might actually be able to tolerate some episodes of fast heart rhythms, like ventricular tachycardia or even fibrillation, better than people without an LVAD.
Interesting. So the LVAD is kind of acting like a safety net?
You can think of it that way. And
Got it.
because of that, the ICD is often programmed to be less aggressive.
Meaning it's less likely to deliver a shock.
Exactly. The focus is more on trying to stop those fast rhythms with pacing.
That's the anti-tachycardia pacing, ATP, we talked about earlier.
Right. So basically, the ICD will try to pace the heart back into rhythm before resorting to a shock.
That makes sense. Less shocks, less discomfort for the patient.
Exactly.
The document also talks about using subcutaneous ICDs, or SICDs, in LVAD patients. What's the deal with those?
Well, SICDs have their lead placed under the skin, not directly into the heart. So that might lower the risk of infections, which is always a concern in LVAD patients.
Sounds good. But are there any downsides to SICDs?
Well, there have been some concerns about potential interference between the SICD and the LVAD. Those two devices might not play well together.
Yikes. That's not ideal.
Not at all. And another thing to keep in mind is that SICDs can only deliver shocks.
They can't do that anti-tachycardia pacing, the ATP.
Exactly. So it's a trade-off.
And what about those tough cases where a patient with an LVAD and an ICD is getting frequent inappropriate shocks even after trying to adjust the device settings and medications?
That's a really tough situation.
Is there ever a point where you might consider just turning off the ICD?
It's definitely possible, but it's a decision that has to be made very carefully, in close discussion with the patient and their family.
It's not something you take lightly.
Absolutely not. And finally, within this section on LVADs, the document also touches on CRT.
Trying to coordinate those ventricular contractions.
Exactly. But the role of CRT in patients with LVADs is even more unclear than the role of ICDs.
So even more controversial.
You could say that. The data just isn't very strong. Some studies have even suggested that having only right ventricular pacing might be better than biventricular pacing in some LVA patients who have CRT devices.
Interesting.
It's definitely an area where we need more research.
Okay, let's move on to Section 9, which focuses on heart transplant recipients.
Those who've received a new heart.
Right. This section specifically looks at patients who are being considered for an ICD, but haven't had any documented arrhythmias after their transplant.
So they haven't had any episodes of those dangerous heart rhythms.
Exactly. But why the concern about sudden cardiac death in these patients? I mean, they have a new heart, right?
You'd think so, but sadly, that's not always the case, even after a successful transplant.
Sudden cardiac death is still a risk.
Unfortunately, yes. And it's a significant risk, even higher than in the general population.
Wow, that's surprising. Why is that? What makes these patients so vulnerable?
Well, several factors come into play. The age of the donor heart matters. Older donor hearts tend to carry a higher risk.
Makes sense.
Then there's the age of the recipient. Younger recipients actually seem to be at higher risk. We'll be focusing on a few key areas.
Right.
How ICDs are considered for heart transplant recipients who haven't had sustained dangerous heart rhythms.
Right.
The role of cardiac contractility modulation, or CCM, as a potential therapy for heart failure.
Yep.
And the latest advancements and considerations in leadless and bradycardia pacing, including the exciting field of conduction system pacing.
Absolutely. Our mission for this deep dive is to be as thorough and systematic as possible. We're going to go through these excerpts that you shared with us methodically, page by page, table by table, figure by figure, section by section. And our aim is to really address every single subtopic, every single data point that's presented, so we can make sure that you have a detailed understanding of the recommendations and the reasoning behind them.
Okay, so let's jump in.
Yeah.
I'm excited to start on page 1262 with section 9, which centers on ICD implantation in heart transplant recipients who haven't experienced sustained ventricular arrhythmias.
Got it.
So we encounter right away table 9.1, which is titled ICD implantation in heart transplant recipients, no sustained ventricular arrhythmias. I think what jumps out at me immediately is it gives you these different situations, and then it assigns a score for how appropriate an ICD might be.
Yeah, I think what's really insightful here is how the table's structured.
Yeah.
So it presents various indications, right? So specific circumstances in a transplant recipient, and then assigns what they call an appropriate use score.
Okay.
On a scale of 1 to 9, right? Yeah. A higher score, as we'll see, generally means there's a stronger consensus on the appropriateness of that decision. And crucially, it takes it even a step further. It looks at the patient's left ventricular ejection fraction, or LVEF, which, as you know, is basically a measure of how effectively the heart's main pumping chamber is squeezing out blood. And so there are two subcolumns here. One for patients who have an LVEF between 36 and 50%. And another for those with an LVEF of 35% or less.
Got it.
So this immediately tells us that the heart's pumping function is a key
Okay.
consideration in these recommendations.
Okay, so if we look at row 286, the first specific indication listed is heart transplant recipient with a history of multiple episodes of cellular or antibody-mediated rejection.
Okay.
Now, for those folks, if their LVEF is in that 36-50% range, they give an M for maybe appropriate, score 5. However, if their LVEF is 35% or lower, it goes up to an A for appropriate with a score of 7.
Right.
So it seems like that history of rejection coupled with the weaker heart really changes the equation.
Absolutely. That's a key observation. Even though these patients haven't had sustained dangerous rhythms, the fact that they've experienced these repeated rejection episodes suggests ongoing stress and vulnerability in that transplanted heart. And so what this table highlights is how much weight the guidelines are putting on the heart's pumping ability after a transplant.
Okay.
So even without a history of dangerous rhythms, a struggling heart, as indicated by that lower LVEF, seems to tip the scales toward at least considering an ICD as a preventative measure. Particularly when rejection's an issue. And that higher score 7 suggests that there's a stronger consensus among the experts that an ICD is more likely to be beneficial in that specific higher risk scenario.
Okay, so then if we move to row 287, heart transplant recipient with evidence of cardiac allograft vasculopathy, the overall score is maybe appropriate with a 6. What's interesting here is that the LVEF subcolumns are grayed out and marked, not rated.
Oh, that's interesting.
So it's as if the presence of this condition just overrides the specific ejection fraction in the decision-making process.
That's a crucial distinction. So cardiac allograft vasculopathy, as we briefly mentioned, is a serious condition where the arteries of the transplanted heart start to become narrowed and hardened. And this can really impair blood flow and increase the risk of all sorts of cardiac events. And so the fact that the LVEF isn't even rated here suggests that the presence of this vascular disease itself is enough to sort of elevate that risk significantly, that an ICD might be considered regardless of how well the heart's pumping.
Got it.
It's kind of like saying the plumbing is compromised.
Right.
So we need to have a safety net in place, even if the pump is still functioning reasonably well.
Makes sense. And then finally in this table, row 288 describes a heart transplant recipient with LVEF hashtag 35% of any etiology.
Okay.
So for this indication, the scores may be appropriate with a 6. And interestingly, the LVEF 36-50% subcolumn is grayed out again, not rated.
Right.
So this seems to emphasize that really severely weakened heart
in
isolation.
Exactly. That's highlighting that if a heart transplant recipient has a significantly reduced LVEF, 35% or lower, regardless of the underlying cause. So maybe it's persistent damage from the rejection, maybe it's some other issue that's affecting the heart, an ICD might be a reasonable consideration. The fact that higher LVEF range isn't even rated in this specific row really emphasizes the focus on the impact of that severely reduced pumping function as a key indicator for potential ICD benefit. Even without those prior dangerous rhythms.
Got it. Okay. So then right below the table, we get a helpful reminder of what the abbreviations mean. So we've got A for appropriate, ICD for implantable cardioverter-defibrillator, LVEF for left ventricular ejection fraction, and M for maybe appropriate. So just to make sure we're all on the same page, a score closer to 9 generally means stronger agreement that the procedure is appropriate. While a score closer to 1 suggests that it's likely not appropriate or even potentially harmful. And so then the maybe appropriate range really suggests that the benefits and risks are less clear-cut. And, more individual patient factors really need to be taken into account.
Exactly. And so if we move on from that table, on that same page, we see figure 24. And it's clearly labeled Summary of Table 9.1, ICD implantation and heart transplant recipients. No sustained ventricular arrhythmias, as the title indicates, This figure is basically a visual representation of the data that we just kind of dissected in the table. And it uses this kind of flowchart structure to present the different indications and the corresponding appropriateness classifications.
Yeah, I like how they do that because it really kind of summarizes it visually. So you can quickly look and see, okay, appropriate, maybe appropriate, based on these different scenarios that we were just talking about, the history of rejection, the presence of vasculopathy,
Right.
and of course the severely reduced ejection fraction.
Absolutely. And again, it includes those reminders
Right.
of what those abbreviations stand for.
Yes. All right. So then we move into this, I think, really important section
Yeah.
called assumptions and considerations. So this is where the authors lay out,
Mhm.
what are the conditions
Yes.
under which they are making these recommendations. So this is kind of like the fine print
Right.
that
Exactly.
helps us properly interpret those scores.
Yeah.
So the very first assumption listed is optimal medical therapy, or GDMT for HF.
Okay.
This is a huge starting point because
Yeah.
it really emphasizes that these considerations about implantable devices only come into play
Right.
after the patient's already receiving
Yeah.
the best possible medication and overall management
Right.
for their heart failure as guided by the clinical guidelines.
Absolutely. That's like a fundamental principle
Yeah.
in cardiology.
Yeah.
These devices aren't meant to be a substitute for good medical management. So the guidelines are assuming that patients are already on board with the appropriate medications, lifestyle changes, all the recommended therapies, and the decision to then consider an ICD
Yeah.
is this sort of additional layer of protection or treatment on top of that optimal baseline.
Okay. And then the next assumption,
Yeah.
consider separate from ICD indication.
Oh, interesting.
Yeah, this is a really interesting point.
Yeah.
Because it means that if a heart transplant recipient also has a completely separate reason why an ICD might be considered.
Right.
For example, if they had a history of sustained ventricular arrhythmias before their transplant,
Right.
that would be evaluated using a different set of criteria
Yeah.
independent of these
Yes.
post-transplant scenarios.
It's about keeping those decision-making pathways distinct.
Yes.
Because the factors that might lead you to consider an ICD in a transplant recipient who hasn't had those dangerous rhythms are likely different from the factors that would prompt an ICD consideration in someone who does have a history of those arrhythmias,
Yeah.
even if they happen to have had a heart transplant as well.
Okay.
So it's about preventing those different risk profiles from being kind of conflated.
Okay. So the third assumption is assume it is feasible to implant additional hardware if ICD is in place. This seems like a more practical consideration.
Yeah, yeah.
It's just saying if we're recommending an ICD,
Yeah.
we're assuming that the actual physical act of implanting it,
Right.
even if the patient might already have other cardiac devices in place, is generally achievable.
Right.
So
Yeah.
it's kind of addressing those real world.
Exactly. It's addressing those real-world challenges.
Yeah.
So if the medical guidelines suggest that an ICD is needed,
Right.
they're also kind of operating under this assumption
Yeah.
that the implant procedure itself is a
Right.
viable option. And this might involve,
Okay.
considerations of space in the chest, the patient's anatomy, potential interactions with other devices.
Okay. And then finally, the last assumption listed here. Assume QRS duration 130 meters.
Okay.
Now, the QRS duration, for our listeners, is a measurement on an electrocardiogram, or ECG, that tells us how long it takes for the ventricles, the main pumping chambers of the heart,
Right.
to electrically activate and contract.
Hmm.
So wider QRS duration often indicates that the electrical activation is either taking longer
Right.
or is less coordinated. But in this context of ICDs and heart transplant recipients without sustained arrhythmias,
Yeah.
they're making this assumption
Right.
that the QRS duration is less than 130 milliseconds,
Okay.
which is generally considered to be a relatively narrow QRS.
And that assumption is quite important
Yeah.
because a wider QRS duration in other heart failure populations might actually suggest
Right.
a potential benefit from cardiac resynchronization therapy, or
Yeah.
CRT,
Yep.
which aims to improve that coordination of the heart's contractions by pacing both ventricles.
Right.
And so by setting this assumption of a QRS duration less than 130 milliseconds, the focus of this particular section remains specifically on the role of ICDs in this subset of heart transplant patients
Right.
who, based on this assumption,
Right.
wouldn't be prime candidates for CRT.
Right.
So it helps to isolate the decision-making process
Got it.
for ICDs in this very specific group.
Okay. And that leads us perfectly into the next part,
Yeah.
where they introduce cardiac contractility modulation, or CCM.
Okay.
So they explain that CCM is being explored as a treatment option for patients with systolic heart failure. So that's heart failure where the heart muscle is weak.
Yeah.
It has a reduced ejection fraction.
Okay.
And these patients typically don't meet the criteria for CRT.
Right.
And one of the reasons they might not meet that criteria is often because their QRS duration is less than 120 milliseconds.
Got it.
Which is even slightly narrower than that 130 millisecond cutoff mentioned in the previous assumption.
Okay. And so what's really intriguing about CCM is the way they describe it works. They classify it as an electrical therapy, but it's different from both pacing, which initiates heartbeats, and defibrillation, which delivers that high-energy shock to restore a normal rhythm. Instead, CCM utilizes these non-excitatory, high-voltage, biphasic electrical pulses, and these pulses are delivered specifically to the right ventricular septum. So that's the muscular wall that separates the two lower chambers of the heart, the right and left ventricles. But here's the key. Only during the absolute refractory period.
Okay, hold on. Let's unpack that a little bit. So even though these are high-voltage electrical pulses, they don't actually cause the heart muscle to contract.
That's right.
Right at the moment they're delivered.
Yeah, the timing is really key here. So the absolute refractory period is this very brief phase after a heart muscle cell has contracted, where it's temporarily unresponsive to any new electrical stimulation. So these CCM pulses are delivered about 30 to 40 milliseconds. After that local heart muscle in the right ventricle has already started to activate and contract, and it's during this unresponsive phase. That's why it's called non-excitatory.
Got it.
They don't trigger an immediate contraction.
So then, if they're not directly causing a contraction when they're delivered, what are they doing? How are they helping the heart?
So they do acknowledge in the document that the exact molecular mechanisms by which CCM exerts its effects are not fully understood. But research suggests that it might work by influencing the strength of the heart's subsequent contractions through these kind of indirect pathways. This could involve affecting how calcium ions move within the heart muscle cells. And we know calcium plays a critical role in the process of muscle contraction. It's also proposed that it might be influencing the expression of genes that actually control the proteins that are involved in regulating calcium handling.
Within the heart muscle cell.
Got it.
So it's not about immediate electrical stimulation leading to a beat, but more about these sort of long-term cellular changes that improve the heart's ability to contract more forcefully down the line.
So it's kind of like a training effect.
Yeah, in a way.
So then moving on to page 1263. Which is section 10, HF and CCM, they make this point that, you know, even though CCM has been approved by the FDA, the clinical experience with actually using these devices in everyday practice remains limited in most centers.
It's an important point to keep in mind. You know, CCM has been given that regulatory green light. But it's still a relatively newer therapy compared to, you know, the more established treatments like medications and CRT and ICDs. And as a result, that widespread familiarity among all cardiologists and the long-term data in a broader range of patients is still evolving.
So it's not quite yet standard of care. Not quite yet,
So the next part goes into detail about several randomized controlled studies that looked at how well CCM works and how safe it is in patients with LVEFs between 25 and 45%. So these patients, you know, they have heart failure with reduced pumping capacity.
So they focused on individuals who had symptomatic heart failure, who are already receiving guideline-directed medical therapy. So the best available meds and management strategies, but who weren't eligible for CRT. And as we talked about before, a common reason is because that QRS duration isn't wide enough to suggest a significant problem. And the findings from these studies have actually been really encouraging.
I was really impressed by that. It looked like they saw improvements in a lot of, you know, patient-reported outcomes.
Exactly. So things like better overall quality of life, reduction in the severity of their heart failure symptoms, as classified by the NYHA functional classification system, an increase in the distance they could walk in 6 minutes, and an improvement in their peak VO2. So that's a measure of their maximum oxygen uptake during exercise. A good indicator of their overall fitness level.
So clinically meaningful.
Absolutely.
Feeling better, doing more, having a better quality of life. Absolutely important goals of treatment. But a crucial point. They weren't specifically designed to definitively assess the impact of CCM on what we call hard clinical outcomes. Like morbidity and mortality.
Oh, right.
So we're talking about major events like
Right.
disease progression and complications, or death.
Okay, so then they go on to mention this specific study,
Yeah.
and it seems like they did see a reduction.
That's right. So in one study,
Yeah,
in a particular subgroup of patients,
yeah. Who had more severe symptoms, those classified as NYHA class 3 or 5, and a QRS duration of less than 130 milliseconds,
Mhm.
and a left ventricular ejection fraction between 25 and 45%.
Yep.
They did observe a statistically significant reduction
Boy.
in the combined outcome of cardiovascular death and hospitalization due to heart failure.
Yeah, so in that group, they actually did see.
Exactly. So it suggests that in
Yeah.
those patients with more advanced symptomatic heart failure who aren't candidates for CRT,
Mm-hmm.
CCM might have the potential to impact
Yeah.
those more serious clinical events, not just their symptoms or their exercise capacity.
Okay, so then they go on to mention a meta-analysis.
Yes.
Now, a meta-analysis basically combines the results from multiple studies to try to get a more robust overall estimate.
Exactly.
And this meta-analysis looked at data from 861 subjects.
Okay.
And they found that compared to a control group,
Right.
CCM was associated with significant improvements in peak VO2, 6-minute walk test distance, and quality of life.
Right, and they measured quality of life using a specific questionnaire called the Minnesota Living with Heart Failure Questionnaire.
Okay. And then they mentioned the FDA approval of the Impulse Dynamics Optimizer Smart System.
Yes.
And this was back in 2019.
That's right.